Technology Officer at DRHA. Today, our meeting will focus on the alarming number of congestive heart failure (CHF) readmissions and measures that can be implemented to decrease these figures. Major issues that we will need to keep in mind today during our discussion include the ethical issues related to e-health monitoring, Health Insurance Portability and Accountability Act (HIPAA) concerns related to e-health monitoring, and the environmental issues that can influence our process and/or decisions. Before we delve into today's topic, let's have our committee members introduce themselves and briefly describe their role within the DRHA organization and the information that they will highlight during today's meeting.
Hello, I'm Yvonne. I'm the CNO participating on reducing CHF readmissions to DRHA. I will discuss how our current EHR system could support the use of remote real-time monitoring data. Readmissions can be prevented by having strong resources in place, both internally in the home and externally post-hospital support. I will also discuss the HIPAA concerns associated with patient confidentiality and the health information technology required in remote monitoring.
Hi, I'm Susanna. I'm the Advanced Practice Registered Nurse working in the Transitional Care CHF program. I will discuss how we are currently monitoring CHF patients post-hospital discharge and present evidence-based data on innovative ways that remote patient-centered monitoring can reduce hospital readmission rates and improve patient outcomes.
Oh, okay. I'm sorry. Hello, I am Diana. I am the Ethics Committee Chair, and I will discuss ethical issues that we foresee that the community will need to address if we were to implement the use of nanotechnology in the form of neurotransmitters, neurosensors, and possibly neuropharmacy.
Today, we will be addressing the issue of CHF admissions at our hospital. There have been an increased number of CHF admissions. The implementation of a program for improved home monitoring of blood pressure, weight, and heart rate has been proposed. It is suspected that the readmitted patients need more monitoring help at home. We are being asked to collect data from hospital records about available patients who are readmitted. Administration is interested in the availability of caregivers in patients' home and their financial ability to hire caregivers.
Oh, Sarah, is that a team formed already to collect this information? And also, are we considering home health in this data collection?
Yes, Dana. The task force to collect the information is already working together. In regards to home health, unfortunately, the majority of our patients do not qualify for home health services due to insurance coverage reasons. Those who do qualify have traditionally been referred to such service though. Some insurances are now being a bit more proactive, authorizing either home health or telehealth. Also, Susanna will cover how we are currently managing CHF patients post-hospital stay.
Oh, I see. My question stems from a 2011 article I read from the journal Telehealth and Telenursing. It analyzed the results of following 8 years in a facility which they instituted a home-based management in CHF. This article itself was called Home-Based Telemanagement in CHF, and it was by Giordano, Zanelli, and Scalvini, and they concluded that this type of therapy, telehealth and telenursing, had a valuable effect on hospital readmissions rates based on the experiences of a total of 358 CHF patients. Yvonne, what information do we have about CHF readmission rates here at DRHA?
We have a task force which is comparing the most recent national data with our readmission rates and post-hospital care information. Certainly, we are concerned about the increase of readmissions for CHF patients. According to an article in the Australia Health Review in 2010, multi-component interventions targeted at high populations that include pre- and post-discharge elements seem to be more effective in reducing readmissions than most single-component interventions, which do not span the hospital-community interface. Susanna, as an APN, can you provide us with some data on patients readmitted with congestive heart failure?
Sure. I'll start by providing some additional information about the scope of the problem. First of all, in the United States, CHF is the most common discharge diagnosis for patients 65 years and older. According to the American Heart Association's scientific statement from 2015, CHF affects an estimated 5.8 million Americans yearly. Nationwide, CHF is the admitting diagnosis in approximately 1 million hospital admissions. Data from the Chronic Condition Warehouse showed that the 30-day rehospitalization rate for patients discharged to home health services was 26%. Of those patients, 42 had cardiac-related diagnoses. These readmissions are associated with a very high mortality rate, and the cost of each readmission is approximately $13,000. With the introduction of the CMS Hospital Readmission Reduction Program in 2012, a hospital no longer receives compensation for these patients who are readmitted within 30 days. At DRHA, our readmission rate mirrors very closely what is seen nationally. Because the rehospitalization risks have not consistently decreased over time, new methods for assessing and monitoring patients are needed. At the DRHA CHF Transitional Care Program, we are looking for innovative ways to assist our patient populations at highest risk. Nationally, research has shown 3 hospital-based factors are important predictors of 30-day readmission. These are evaluation of left ventricular function, smoking cessation counseling performance measures, and the number of heart failure admissions a patient has had per year. Although this information is readily available through the DRHA electronic health record system, according to the United States Department of Health and Human Services, the Health Insurance Portability and Accountability Act of 1996, better known as HIPAA, protects individually identifiable health information as protected health information. As such, we need to ensure that we are using this information ethically. According to the 2013 article by Pearson, DeMuro, Goodman, and Kaplan, this ability to gather data from multiple sources is an integral part of quality improvement.
Thank you for the overview of the problem, Susanna. Before we get into solutions to the problem, I'd like to take a few minutes to review our current processes. When a patient is admitted to the hospital, we ask about barriers to discharge, including lack of home support, housing, financial concerns, etc. We know our electronic health record triggers referrals to the appropriate clinician once any of these questions are answered yes. In preparation for this meeting, I created a subcommittee with nursing, care coordination, social services, and a hospitalist to look at our current processes. Our 850-bed hospital discharges about 250 patients daily. In reviewing our admission questions, we found that nursing was appropriately documenting concerns and that these concerns were triggering referrals to care coordination and social services. However, when we looked to find the consult notes, 20% of the CHF patients with identified needs had not been evaluated within 1 day of their admission. We invited Performance Excellence to our committee and did a root cause analysis. Our findings showed that both care coordination and social services are seeing an increasingly ill population. Patients undergoing transplantation and chemotherapy were high on their priority, while CHF patients were considered low priority. As we continue in our understanding of this issue, I am prepared to be open to suggestions that this committee has to offer, such as a reorganization of care coordination and social services, and the potential need for additional resources. I would like to caution that I don't believe additional resources are a success unless there are strong processes and measurements in place. Furthermore, as we explore nanotechnologies to improve patient outcomes, as described by Staggers, McCaskey, Brazelton, and Kennedy in 2008 article, we must take into consideration that the advent of nanotechnology could create policy implications for consumers, especially for privacy and ethical issues. And as Peterson, DeMuro, Goodwin, and Kaplan stated in 2013, to receive appropriate and effective healthcare services, patients need to be able to trust the professionals who care for them.
Currently, DRHA is considering promoting the use of nanochips that attach to the wrist of frequently readmitted patients that will send daily blood pressure, heart rates, and possibly uh, pertinent blood levels back to monitor in cardiac unit nursing station. DRHA administration would like to incorporate this information and communication technology in the form of real-time remote monitoring with the use of these nanosensors to help monitor those who don't have caregivers in the home to help them and intervene before an exacerbation of heart failure.
Yes, Sarah, we frequently see that our patients and their families are overwhelmed regarding the skills and knowledge required in their self-care management. As detailed in the 2008 article published in Nursing Outlook by Staggers, Mikulski, Brazelton, and Kennedy, nanotechnology has allowed biochips to be developed for use in patient monitoring devices. These electronic health applications for real-time home monitoring have been cited as promising tools to improve treatment compliance and promote individual patient-centered care. The expectations are that these e-health applications will lead to improved treatment outcomes, patient safety, and a more efficient use of healthcare resources. CHF affects 10 to 20% of the population aged 70 or greater. These group of patients are associated with significant healthcare costs. If e-health interventions can help better manage these complications, then not only would the patient and their families benefit, but so too would society as a whole. According to Gunn, Lindekrantz, Patel, and Sovitz in their 2012 article published in Biomed Central Medical Informatics and Decision Making, some of the barriers to the widespread use of e-health technology are the lack of infrastructures to support data generated and resistance on the part of healthcare professionals to incorporate advancements in information and communication technology.
Diana, what are the main ethical considerations that surround the use of this technology?
Well, there are a few ethical issues that we are concerned if this technology was to be adopted at the RHA. There's three basic components of concerns that are one, patient-provider base, two, technology support and interfacing, and three, responsibility of the outcomes if we use a nanosensor. So first, allow me to give you a background in the ethics surrounding the field. Healthcare providers might feel like this nanotechnology has a whole new ethical reflection and contextualization that need to be developed as the ethical considerations might lag behind the actual nanotechnology improvements. But according to Danny Meadow of the British Journal Nursing back in 2009, we might not be able to ever catch up with the pace of the advancements. So we might have to then apply the major ethical principles that we have always used in nursing, such as beneficence, autonomy, non-maleficence, and justice.
So that makes sense in such a fast-changing field.
Yeah, so consideration number one is patient-based concerns, patient and employee-based concerns. So patient will be things about cultural, personal, or religious restrictions of the implantation process. The ethics team attempted to do a search in many of the main searches in PubMed and CNOW and in our own library to find resources information on this topic, but it was unsuccessful, and that might be an issue to be discussed individually with each patient. So, second, patients-based concern is the financial equality, as our contractor insurances are not at this point covering the expenses to use nanotechnology. The third, we might not be able to guarantee safe handling of these devices for both patients and providers, as described in 2010 article by O'Malley called Nanopharmacology, for the Future Think Small, written by for the Journal of Advanced Nurse Practice. The nanosensors, being so infinitely micro, have shown to cross the blood-brain barrier and enter cellular environments where they might potentiate certain medicines or clinical problems. So the patient risk might be intensified. It might also pose long-term effects of nanotechnology in nanodevices, as themselves are relatively new. It has been noted in an article by Stakers et al. Called Nanotechnology: The Coming Revolution and Its Implications for Consumer, Clinicians, and Informaticists, that the current personal protection equipment (PPE) equipment that our employees have is not protective enough of such a tiny devices, so they could potentially become embedded on the skin, or they could be inhaled by a provider inadvertently by a provider or a patient. So that's about the patient and the provider. Our issue number two has to do with the technology and the interfacing. So currently our hospital's EHR is not equipped with communicating or interfacing with any of the current nano devices, which means that even if the patient receives a device, the challenge lies in how are we to acquire the information and if we are capable of interpreting it. Issue number three, and for my purposes as an agent of mitigation of hospital liability, is that a clear line must be delineated to designate the responsibility of the provider and the patient, because if sensors provide alerts to thresholds, how do we assure that those patients follow the suggestions or the alerts, and or that the provider gets such alerts in a timely manner? However, currently we do not have a market-wide device, so we will continue to revisit these concerns, but we won't act on them until the devices are real in our location. So far, MIT seems to be the closest to manufacturing such nanosensor, and it is still not on the market. So Susanna, please let's explore what the current patient transition post-discharge. Let's explore about the current patient transition post-discharge decision.
Okay. Well, our current CHF transition care program currently has 8 main components. These include telephone follow-up, education, self-management, weight monitoring, dietary advice, exercise recommendations, medication review, and social and psychological support. Patients are contacted post-discharge at 24 to 48 hours, day 10 to 15, day 20 to 25, and day 30 to 31. Although these interventions have resulted in a slight decrease in 30-day readmission rates, there is definitely an opportunity for improvement. According to the 2015 American Heart Association Scientific Statement on Transitions of Care in Health Failure, one of the clinical practice and research recommendations that promote enhanced patient outcomes is the early assessment of the patient's needs in the home setting. Early identification of caregivers increases the likelihood that their involvement of their involvement in pre-discharge education. Patients without caregiver involvement are deemed to be high risk.
Okay, the last thing I would like to talk about is the environmental issue that related to the nanotechnology utilization. Staggers, McCaskey, Brazelton, and Kennedy, in their 2008 article, defined nanotechnology is design and manipulation of materials at the atomic and molecular scale. The large amount of atoms can contact with humans, animals, or the environment anywhere. The individual may accidentally inhale therapeutic products. According to Stefaniak et al. In their 2012 article published in Nanotoxicology, the characterization of exposure of nanomaterials and the toxicity is needed for understanding and managing potential risk exposure to humans and the environment. There are only 10% studies contained information on nano-object physical chemical property. This uncertainty is creating an uncertain safety and regulatory environment. Klein et al. Addressed same uncertainty in their article published in Environmental Toxicology and Chemistry 2012. The authors stated as with most contaminants in the environment, nanomaterials can be expected to end up in aquatic ecosystems or soil. Payne et al. Illustrated that antimicrobial wound dressings containing nanocrystalline silver may release antimicrobials into the environment, a hazard to natural microbial systems. Unfortunately, the lack of hazards assessments has resulted in both humans and environment being exposed to nanomaterials without adequate information. So at this point, nanotechnology is advancing at a fast pace, and the availability of a nanosensor capable of sending vital information is very real. However, the information and communication technology is not in the mass market yet. At that point, identifiable patient information will need to be protected in compliance with HIPAA regulations. This patient-focused data collection will allow for quality improvements in our post-discharge management of CHF patients. Secondly, based in reimbursement factors, such as not receiving payment if the patient is readmitted within 30 days of discharge, we agree that improvement of current follow-up program is needed. We could activate telehealth when appropriate and have stricter guidelines for discharge so that patients are not sent home prematurely, putting them at a higher risk for readmission. We would have the data from the task force by next meeting and can vote on steps to follow.
Okay, I agree.
I agree.
Thank you to everyone for another great session on how to decrease the readmission rate of CHF patients. We will meet next week for another case study presentation. Everyone have a good day.